Hi, my name is Jodian Hudson, and this is my General Parasitology MB480 presentation on my interview with Dr. Regine Brioche. Dr. Brioche was born and raised in New York and has been in practice as a board-certified pediatrician for over 10 years. She has worked in both public and private sectors of healthcare. She is currently working at Tribeca Pediatrics, which is a private practice. I too currently live and work in New York. My first question I asked Dr. Brioche is, how often do you have patients with parasitic infections? She answered that working in City Hospital, she would see these types of infections once per day. However, this has been reduced during her current position working in private practice to approximately twice per month. This is an indication of the difference in population seen in the different sectors. I will talk more about this in the next slide. My second question for Dr. Brioche was, what are the three most prevalent parasitic infections you have treated? She answered, pinworms, which are Enterobius vermicularis. This is usually asymptomatic. It is commonly found in kids 6 to 10 years old. The most common symptom is perianal itching. The second most prevalent parasitic infection was head lice, also known by scientific name as Pediculus humanus capitis. This head lice is different from the lice that causes pubic hair and body infections. You can see a picture of the pinworm in the lower left-hand corner in the petri dish. The adjacent picture is a picture of the head lice. Pinworms and head lice affect middle to upper class population equally, which she does see more often in her current practice. More often than scabies, which is usually affected in population of the lower to middle class. This is because they live in more cramped and crowded conditions, which facilitate this type of infection. Treatment for head lice and pinworms can be acquired over the counter because they are so commonplace. Of the three most common parasitic infections, I have decided to focus on scabies, which I will discuss in further details in the remainder of the presentation. Scabies is caused by the parasite Sarcoptes scabii var hominis, also known as the human itch mite. It causes cutaneous infestation. It affects individuals of any age group. Its prevalence is worldwide in an estimated 100 million people. And as mentioned before, it is facilitated by and easily spread in crowded conditions. Above is a picture of the human itch mite, Sarcoptes scabii. Sarcoptes scabii is not zoonotic. Humans are the definitive hosts, and there are no intermediate hosts. It is transmitted mainly via skin-to-skin contact, where impregnated females can pass from person to person. Transmission can also occur via bedding or clothing of the infected individual, although this is usually not common. Males are much smaller than females. Females are 0.30 to 0.45 millimeters long and 0.25 to 0.35 millimeters wide. The adults are eyeless, round, sac-like with 8 legs. The upper left picture shows an image of the scabies mite. The lower right picture shows an image of the burrowing into the skin. Life cycle. Sarcoptes scabii undergoes 4 stages in its life cycle: egg, larvae, nymph, and adults. This can be seen in the top portion of the slide. Females deposit 2 to 3 eggs per day as they burrow under the skin. Eggs are oval and hatch in 3 to 4 days. After the eggs hatch, the larvae migrate to the skin surface and burrow into the intact sternum corneum to construct burrows called molting pouches. The larva stage, which emerges from the eggs, has only 3 pairs of legs and lasts only 3 to 4 days. After the larva molt, the resulting nymphs have 4 pairs of legs. This form molts into slightly larger nymphs before molting into adults. Mating occurs after active male penetrates the molting pouch of the adult female. Mating takes place only once and leaves the female fertile for the rest of her life. Impregnated females leave their molting pouch and wander to the surface of the skin until they find a suitable site for permanent burrow. Upon finding this site, it begins to make its characteristic burrow, laying eggs in the process. After the impregnated female burrows into the skin, she remains there and continues to lengthen her burrow and lay eggs for the rest of her life, approximately 1 to 2 months. About 10% of her eggs eventually give rise to adult mites. The lower portion of the slide shows person-to-person transmission. Symptoms. There are 2 manifestations of scabies. The most common is classic scabies. This is characterized by intense itching and pimple-like skin rash, also known as papular. Both are the host's reactions to the parasite's feces and proteins. Classic scabies is usually found between the web of fingers, wrists, elbows, waist, and many other parts of the body. This type of scabies usually has 10 to 15 mites. As a result of this type of scabies, a secondary bacterial infection can also occur. These are examples of classic scabies. A second type of scabies is called crusted scabies or Norwegian scabies. This is severe and affects individuals who are immunocompromised and the elderly. It is characterized by thick crust over the skin. Itching may be absent due to the immune system being compromised. This type of scabies can have many mites present, up to 2 million, and because of this, it is very contagious. These are examples of crusted scabies. Diagnosis. Scabies is initially diagnosed via rash or the mites burrows. You can also ID the mites, mite fecal matter called scibala, or eggs via microscopic examinations. Some individuals may be infected, although they might display the absence of mite or eggs. These individuals usually have fewer than 10 to 15 eggs. Treatment. The most effective treatment is permethrin. This is a topical treatment. Ivermectin is also another option for treatment. This is oral. Either can be used for classic scabies. For crusted scabies, a combination of permethrin and ivermectin is usually recommended. An antihistamine can also be given as part of treatment because itching may continue for up to 4 weeks after successful treatment. Control or prevention. It is recommended to treat everyone in the household or whom have had prolonged skin-to-skin contact with the infected person. Wash the bedding and clothing of the infected person. Thoroughly clean and vacuum living quarters of the infected person. Avoid contact with the infected person. And general public education and awareness are also methods to help control the spread of scabies. I have asked Dr. Brioche about one of her most memorable cases, and there weren't any that stuck out about patients with scabies. However, she did recall a case where a pregnant woman was diagnosed with toxoplasmosis. Toxoplasmosis is caused by the parasite Toxoplasma gondii. Cats are the definitive hosts for this parasite, and humans can be the accidental host. Toxoplasmosis is spread mainly through exposure with infected cat feces or food contaminated with parasite cysts. Toxoplasmosis can be very problematic for pregnant women, as it can cause fetal death or abortions, neurological defects in infants due to calcifications in the brain. One of the things that was interesting about this case is that the pregnant woman did not own a cat or encounter a cat leading up to her diagnosis. It was determined that she became infected by eating contaminated deli meat. During the pregnancy, they performed an amniocentesis to determine if the fetus was infected with toxoplasmosis. The fetus was, in fact, negative. They continued to monitor the fetus and, upon delivery, tested the infant again, and the results were again negative. The infant is currently symptom-free and continues to test negative for this disease. Despite this, there is still a chance that this infant could develop toxoplasmosis. However, as this infant ages, this becomes less likely. These are the sources used for my presentation.